Next slide.
Yes. So shall I start?
Yes, sir. Yeah.
Okay. See, I on behalf of the organizing committee and the IPS pharmacotherapy subcommittee, along with our convener, Dr. Tirthankar Das Gupta, Dr. Rajesh Dhuma, who is an advisor, and Dr. Kaushik Chatterjee, who is the EC coordinator. Also the IPS bearer, Dr. Aren Raju, our current IPS president, Dr. Vinay Kumar, vice president, Dr. Arbindur Brahma, our honorary general secretary, Dr. Siddiqui, our treasurer, and Dr. O.P. Singh, our editor. Welcome you all to the second in line of the topic of the pharmacotherapy subcommittee. And we plan to continue this as once in a month. And we are planning to get into topics which are of very much clinical relevance, topics which make sense to the clinicians, topics which are normally in day-to-day practice, but sometimes overlooked. We are planning to do topics like psychotropics in pregnancy in the subsequent section, then psychotropics and hyperprolactinemia, melatonin, and autism.
Yeah.
So we're also trying to include young speakers. We are trying to include new people with certain new techniques, new adding to our knowledge base with a lot of fire. So I think this goes on nicely. We also plan to do twice in a year physical conference. One we are planning in Jammu somewhere around Diwali and before Diwali, I think so. And the second possibly in Goa. So this is how we are planning for the subsequent year, and maybe some online quizzes and some sort of interactive and involving postgraduate students. This is our next aim. So I think along with the convener, possibly he is managing the whole show by himself. So I welcome you all to today's topic, and I hand over the current proceedings to our moderator. Please.
Thank you, Dr. Manu Arora. And as we said, we are planning to have series of these cutting-edge topics to be delivered by some young, enthusiastic, upcoming, brilliant psychiatrists of India. Now, I welcome all the IPS Indian Psychiatric Society office bearers, and I would request first our honorary president, Dr. Aren Raju sir, to say a few words about our program. Please.
Thank you. Thank you, Dr. Tirthankar. Am I audible? Yeah.
Can you please mute other microphones and just unmute the speaker's microphone only?
I think they can mute all others except the whoever speaks, I think.
Anyone from the...
Why are we seeing Dr. Nina Bora's screen? Okay. Raju sir, please start with us.
Anyone from the back end, can you please mute the microphones of all the delegates? Just unmute the speaker.
I think Hitenmoy is there, na? Hitenmoy?
Yeah, Hitenmoy. Yes, yes, please.
Nina Bora's screen.
Yeah, I think I'm audible now.
Yes, sir. You are audible.
Yeah. Good evening, friends. And at the outset, let me thank the pharmacotherapy section for organizing series of updates in an area where most of us are really enthusiastic to listen to, and also perhaps the mainstay of our work has been the pharmacotherapy, and I'm happy that the people who are in that committee have come into that by their choice. If I'm right, I think Rajesh wanted it, Manu wanted it, Tirthankar has always wanted a biological based section. So we kept them there, and I'm sure they will do a lot of good in the few months and years or whatever, as long as they stay there. And I'm also happy that they have identified some young guns to deliver the lectures, which is very important because I know we have a lot of good people across the country who have been doing, I think, excellent job for the last 2-3 decades. We know that. Suppose if you take an example of Chittaranjan Andrade, I think just out of the world lectures he gives, and we know that. So I think it's time for us to identify somebody may not be equal to him, but somebody who can fill that gap once he, I think, hangs up his boots. I know he's active, still he can give an young fellow a run for his money. But still, I believe that I think the job of this committee or a section should see to it that please identify people in all corners of the country, give them the platform. I know even if you can succeed 1 out of 10, I think we have done our job well. So probably in this direction, I request all of you to see to it that some young guns or young talent is identified and given the choice to speak at the national level. And also, may I remind you all that it is surprising that IPS did not have a pharmacotherapy subcommittee or specialty section or task for anything till this year, because you have n number of psychotherapeutic subcommittees or specialty sections or task forces, but exclusively for pharmacotherapy there is nothing. And I thought that this year we will start one, and I'm happy that I put in the hands of 2, 3, or 4 brilliant people, including our EC coordinator. So I think we are looking forward to an excellent series. And if I remember right, Manu is likely to organize a physical meeting in Jammu sometime. So hopefully this will also get culminated. So, but whatever it is, we all are looking forward to a brilliant series of lectures. And may I request this group also see if get some documents from these speakers. If we can compile them at the end of 1 year, even a soft copy, I think that would be a great idea. Let with your name, because your name in the front page itself. So let the committee bring out a document in each. Suppose they spoke about something like, let us say, mood stabilizers, or somebody speaks about antidepressants, or whatever it is, whatever they have spoken today, let them present a 3-page, 4-page, 5-page, whatever the committee feels good. Let them have maybe at the end we will have a booklet, and hopefully we will be able to do that. Please do that, right? So I wish you all the best and wish you success as for this program. Thank you so much for inviting me to give the introductory remarks. Thank you so much.
Thank you so much, Professor Raju. Thank you so much for delivering this excellent initial introduction. Now, Dr. Binay Kumar, sir. Sir, are you there? If you can say a few words about our program. Vice President cum President-elect, Dr. Binay Kumar, sir. Sir is there. I'm not able to see him. Okay. Dr. Honorary General Secretary, Dr. Aravinda Brahma, sir. Sir is already there. Dr. Brahma, Aravindoda, if you can say a few words about our program.
Thank you, Tito. First of all, special thanks to IPS pharmacotherapy subsection for having this meeting for 2 consecutive months. And as you have expressed, Dr. Monu has expressed that you want to do it every month. That's a brilliant idea, I think, especially for us and for the young generation also. We can learn a lot from this type of programs. We can have the updates as well. And I request Tirthankar that every time you are doing the program, just send me a report in the AGS office, so that at the end of the year we can publish it, that from your subcommittee, because it is one of the most active subcommittees. So what you have done throughout the year. So you can start doing this from this time only. And what Dr. Raju sir has also told, you can compile the different speeches. And regarding today's topic, I'm not going to tell anything, because we have many important speakers. Dr. Nachiketa is there, and Sandeep and Abhirda is there to chair the session, and our dear Niska is there to moderate it. So I don't want to waste much time, but I think I must thank Dr. Rajesh Dhume as advisor of this specialty section, along with our dear brothers Manu and Tirthankar as chairperson and convener, and Dr. Kaushik Chatterjee as EC coordinator. Hope we'll get every month a very interesting topic, a very clinically relevant topic that will help us to update our own knowledge. Thank you. Thank you. Over to you, Tirtha.
Thank you so much, Aurobindo Da, Dr. Aurobindo Brahma, our dear Honorary General Secretary, IPS. Now, Dr. OP Singh, sir, are you there? Honorary Editor, Indian Journal of Psychiatry. Dr. OP Singh, sir. I'm not able to see him. Okay. Now, Dr. Alim Siddiqui, Honorary Treasurer. My friend, Dr. Alim Siddiqui, are you there? If you can say a few words.
Yes, thank you, Dr. Tirthankar.
Yeah.
Thanks to the committee. My regards to Raju sir and all the office bearers of IPS. I think this is a wonderful initiative you guys are taking. So I think just my good wishes, and please carry on the good work. All the things have been said. Let me not come between you all and Nachiketa, whom we know so well. Nachiketa, all the best, and all the best to the committee. Thank you so much, sir.
Thank you.
Thank you, Alim. Thank you so much, Alim. Now I hand over my mic to our brilliant moderator, young gun, and upcoming psychiatrist, Dr. Nishka Sinha from Patna. And
Tirthankar, Dr. Gautam Saha is also there. You can invite.
yes, I forgot. I am very sorry. I forgot Dr. Gautam Saha. Gautam, are you there? Yes, he is there. Yes, dear. Gautam, if you can say a few words, the president of Search Psychiatric Federation, Dr. Gautam Saha, if you can say a few words about our program, we will be so much honored.
Tirthankar, nothing to say more. Already our president elaborated everything. So what I'm thinking, really the group is fantastic, led by Dr. Dhume, Dr. Manu, Dr. Tirtho, Dr. Kaushik Chatterjee, and today's faculties are also fantastic, like Dr. Nachiketa, Dr. Sandeep Grover, Dr. Abir Mukherjee, and moderator, our dear Nishka. It is really great, and I don't want to put anything else, but the good suggestions came. I hope that, and I am confident that this committee will do fantastic job as a psychotherapy subcommittee. Thank you so much. Thank you, everybody.
Thank you. Thank you, Gautam Da. Thank you. Need your suggestions and your advice in future also. Sorry. Now, I would ask, and anyone from Tonent, if you can share the slide. First,
Sure, sir.
Dr. Nishka Sinha, our moderator, brilliant upcoming psychiatrist, young gun, psychiatrist from Patna. Yes, Dr. Nishka Sinha, today's moderator. She will be moderating the entire program. Dr. Nishka Sinha, the assistant professor, Department of Psychiatry, Indira Gandhi Institute of Medical Sciences, Patna. The MBBS and MD Psychiatry, 10 years of experience she has. Is a member of Indian Psychiatric Society, IACAM, zonal representative of State Indian Psychiatric Society of Bihar State Branch, member of CIP, and she has passed from CIP Ranchi. She has more than 12 publications in Index Journal, 5 book chapters, currently involved in 7 ongoing researches and 2 ICMR approved projects. Her area of interest and specialization is community psychiatry, women mental health, consultation liaison psychiatry, and she actively participates in various conferences, seminars, awareness programs. She's very much active in the field of psychiatry. I hand over my mic to Dr. Niska Sinha for further proceeding. Thank you, Dr. Niska Sinha. Thank you. Yeah.
Thank you, Tirthankar sir, for the lovely introduction, and I feel humbled. And also, I think it's a pleasure that we had words of blessings from our IPS president, then our very beloved SARC president, Dr. Saha sir, as well as Dr. Aravindo sir and Alim sir. So office bearers, and it has been like all the stalwarts of psychiatry, they are on one platform. So it's a blessing for all of us. Today's topic was the name itself is very catchy. The happy pills, about this. So relevant to this, before we begin formally, a data I would like to share, which is a United Nations data of 2022, which says that out of 146 countries, India ranks 136 among the happiest countries, the happiness index. So just imagine the happiest country at #1 position is Finland, and we are way behind. So it's very important. Everybody wants to be happy. And in regards to that, we have a very important discussion today on happiness pills, like are antidepressants happiness pills? So, and we have a very prolific speaker also, Dr. Nachiketa with us. So not wasting time, I would like to start with the introduction of the learned chairpersons we have for today. Hitin, can we have the slides? Dr. Sandeep sir. I think sir needs no introduction, but as customary, Dr. Sandeep Grover sir. Yes. So sir, well, sir is from Chandigarh, as we all know. Sir is Professor, Department of Psychiatry, PGI, Chandigarh. And about publications, what to talk of publications, he has 786 publications, I think 69 book chapters, and he has edited 4 books. So I think the number of book chapters I have read so far, or the number of publications I have gone through it, sir has been the writer, I think, writer for those many publications. And he is editor for Journal of Geriatric Mental Health. He has been editor for Journal of Mental Health and Human Behavior, Indian Point of Care, Journal of SARC, Psychiatric Federation. So sir has edited so many journals. He is associate editor for Indian Journal of Psychiatry since 2009 onwards. So that has been a huge task. And Journal of Psychosexual Health 2018 onwards, Indian Journal of Private Psychiatry, and there has been numerous awards to sir's credit. He has been awarded thrice by Indian Council of Medical Research. So we have a chairperson who has been a teacher for all of us. So we are blessed to have Dr. Sandeep sir with us. Next slide can we have for Dhume sir? Because of some personal issues, Dr. Abir sir couldn't join today's meeting. So today we have Dr. Rajesh Dhume sir from Goa. And as I said, both the chairpersons are so learned, and in the field of psychiatry, I don't think I need to introduce them. But Hitin, can we have Dhume sir's slide? Hitin? So about Dhume sir, sir has been a senior psychiatrist, though he doesn't look as senior, he looks all young. And he's IPS, he has IPS membership, he has been a life fellow of IPS, President Indian Psychiatric Society Western Zonal Branch, Vice President Indian Psychiatric Society Western Zonal Branch, and President-elect for 1890. Chairperson IPS Physical Therapy, Secretary IPS Goa State Branch, President IPS Goa State Branch, Honorable Zonal Secretary, A very important thing about sir is he has worked on suicide prevention helpline projects of the IPS Goa state branch from 2004 to 2010. So, and about academic contributions, sir has co-drafted the Goa Mental Health Policy 2003, which we are all aware of, which has been a very substantial contribution, and suicide prevention project for Goa in 2004. Sir has publications, ICMR projects, and IGP. He has contributed 2 papers. About sir, he is a known social worker also of his area and founder member of Dementia Society of Goa. So many things to credit in credit of sir. Executive Council member of Indian Association of Geriatric Mental Health. And since I have been associated with sir, the most important thing is sir is such a humble and always motivating persona. We always look forward to sir. So we have him as a chairperson, so it will be a great learning experience for all of us. So now I think I hand over to our chairpersons for the introduction of our speaker for today, Dr. Nachiketa. Can we have slides for Dr. Nachiketa?
Yeah, good evening all, and I think I'll take the privilege of introducing Dr. Nachiketa Desai from Gujarat. He's a consultant psychiatrist, and as Gautam Da and our seniors said, that he's a young gun, but truly so. He's completed his DPM from BJ Medical College. Probably must have been topper in his times from Ahmedabad in 2015. First year in service and 1 year in service in government psychiatry in Daman, and then in private practice from 2017. His interests are biological psychiatry, transactional neurosciences, and personality from the lens of the neurobiology. Very interesting. So it's a great pleasure to welcome you, Dr. Nachiketa. And over to Dr. Sandeep Grover, my teacher colleague, to give some thoughts about what is his idea and how he is paving the line for today's lecture. Over to Sandeep, sir. Is there an audio problem, Tirtha, for Sandeep, sir?
I guess a little bit audio problem. Sandeep, sir, are you there?
Am I audible? Yeah,
Yeah,
I'm there.
Yeah, a little bit. There's a breaking in your voice, Sandeep.
Is that okay now?
Yes, it's okay now.
Yes.
Yeah.
I'll go off audio, go off video. You get a little more bandwidth. Okay,
Yes.
Arvindo, let's go off audio.
Is that
video.
okay?
Yeah.
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 Good evening, everyone. Am I audible now? Hello.
Your sound is cracking, Shandeep. Sound is cracking.
Okay, that is the bandwidth I have. Maybe if you give me 2 minutes, I'll then log in from another device. Otherwise,
No
just
problem.
give me 1 second. Just give me 1 second. Yeah.
Recording in progress.
Am I audible now? Better?
A little
Yes.
better. Yeah.
And I would like to thank the Psychopharmacology Task Force for inviting me to chair this session. It's an important session. I could say that when we discussing antidepressant drugs. And I would also like to thank my co-chair, the moderator, and the IPS office bearers for asking me to be part of this program. When we talk about antidepressant as whether they are happy pills or not, we need to understand that the word happy pills have been used in the literature. In people try to use this in the blogs and other things with respect to either the anxiolytics, antidepressants, or for that matter, any kind of psychotropics in relation to the mental illnesses. And the basic, however, the debate has been around antidepressant and whether these are happy pills or not. And some people try to talk about this, whether a person who has depression requires only antidepressant, or people those who are not actually depressed may also benefit with antidepressant. That's the kind of issue which keeps on cropping up when we look at the how the word happy pills have been there. So I'm looking forward to listening to Dr. Nachiketa, how he conceptualizes his talk about this topic. And once he completes his topic, good discussion. So over to Dr. Nachiketa.
Thank you, sir. Am I audible? Hello.
Yeah, you're audible.
Okay, sir. Respected President, sir, all the dignitaries, and all the respected seniors, thank you for providing me this opportunity to put forward few of my thoughts. They may not be uh, able to do the justice to this topic, but I will try my best. This topic, although looks simple, but it has so many technicalities and so many angles to consider that it's not possible to cover all those things in one seminar or one lecture. So I'll try to keep it very simple, and rather than going into technicalities too much, I would rather try to provide a stimulation to look at these molecules in a different light. To begin with my presentation, I will just share my screen now. Is it visible now?
Yes, it is. Yes, it is.
Okay, so as today's topic is antidepressants are not happy pills. And how did this concept come about? Already sir has mentioned a few points, but I would like to mention my journey. In MBBS days, we used to read a pharmacology book called Eddie Tripathi. In those days, I had very different notion of what an antidepressant is, and then I used to think that, oh, alprazolam has a mood elevator or antidepressant properties, and I used to get confused with which one is which. But when I joined PGT, we all read standard textbooks, which is focusing mainly on neurotransmitter theory. And in neurotransmitter theory, particularly about monoamine hypothesis, how serotonin, noradrenaline, dopamine are key players in probably pathogenesis as well as correction of depression. But since I completed my PG and started pursuing things on my own, I have come up with, I was faced with such an amount of literature that I have not yet been able to completely read and realize that these things go far beyond just monoamines. So all this starts with basic definition or conceptualization of depression. How we define that? We define it with the help of DSM or ICD, which are in a way symptom checklist, or we can say clinical presentation, or we can say phenotype, or we can say syndromal diagnosis. And of those, key criteria is low mood or sadness, and treatment gets you back to normal. That is, it makes you happy. And to describe all these things, research has used technical words like absence of negative affect and presence of positive affect as a sign of recovery or remission from depression. However, antidepressants improving brain function and a person feeling less sad or starting to feel happy again can also be considered a byproduct or an end result rather than primary action. So what are the happy pills actually? So they are technically called euphoria, something that generates happy emotion, even in normal person who would take that. This calls back to what Grover sir said about whether a normal person would get same reaction with antidepressant as a person with depression. Examples of euphoriants are cocaine, opiates, stimulants, practically any substance of abuse that gives you kick and produces that euphoria. And this action may be lasting for a short while till the effect of that molecule wears off. Compared to that, our antidepressant medication, so-called antidepressants, they are not usually euphoriants and their effects are not immediate in almost all cases because they take time to improve brain function. Once a person with depression recovers from it, then he starts feeling full range of emotion. He would feel normal ups and downs of life too, but he would be able to bounce back from negative emotions and be able to feel pleasurable emotion. Those terms, negative and positive effect. Thus, antidepressants have impact. They do provide happiness by recovery from depression, but their impact does go far beyond just emotions, as we will see in further slides. So, as we have seen, antidepressants are not happy pills. What are they? First of all, term antidepressant itself is a misnomer because they are used in other conditions too. For example, anxiety or migraine and many other conditions. For example, we use imipramine for nocturnal enuresis. And with regards to that, there is an interesting article in Primary Care Companion CNS subsection. The articles or the links that I am mentioning in this presentation are just demonstrative, one or two example just to demonstrate the point because there are so many examples and so many things to cover in such a short time. So this is the thing. That term is misnomer. What do we call it then? We can probably call it functioning enhancer or we can call it resilience promoter. But these terms are in neurobiological senses. And to understand that, we need to look at depression and every other psychiatric disorders from the point of view of brain. Here, we are talking about so-called antidepressants. So I'll be considering depression and what happens to that brain. But general outline is applicable to other disorders also. For example, a depressed or an ill brain is not able to meet functional demand. In technical terms, it will not be able to maintain allostasis. That will impact various systems that brain controls, autonomic nervous system, neuroendocrine axis, immunological functions, everything. And that can impact and produce symptoms all over the body. Those functional GI symptoms, functional urinary symptoms, palpitation, everything. And this can be understood via concept of allostasis and revised stress diathesis model. Why revised? Because originally that model was given in 60s by I think Joseph Lucas in context of schizophrenia, and it had a psychological founding that a person having diathesis has a psychological stressor or a life event that produces illness or precipitates the symptoms. But it is applicable to biological aspects also, and primarily Bruce McEwan has worked on this by providing or coining the term allostatic load index, if I remember correctly. So neurotransmitter action does occur, but it is initial action for first 1 month or so. Then receptor upregulation, ion regulation, and other factors come into picture. After that, some other actions take over. And if those actions don't come up prominently, we see the loss of effect, which is termed by poop-out effect by one prominent writer, author, that book we read in UG days, PG days, sorry. So once the molecule binds to neurotransmitter channel or receptor, these receptors are basically G protein coupled receptors largely. It triggers intracellular signaling cascades and thereby calcium level changes from endoplasmic reticulum to cytosol, and there are basically transport of molecules in and out of cell, new protein production, all these things plus intranuclear area, transcriptional, post-transcriptional, post-translational changes, which ultimately improve intra and intercellular functioning. And thereby, a brain is able to function better. This is a rough timeline of what we have discussed in previous slides. Serotonergic or noradrenergic release and action is on a time scale of minutes. That signal and activation of subsequent signal transduction pathways like CRAB or MAP kinase is in hours, which changes gene expression intranuclearly. That is again hours to days, and which ultimately leads to dendritic changes, because we see loss of dendritic density or arborization in various different areas in cases of depression, which get reversed with effective treatment. So this is general outline, very general. I won't be going into each and every step and technical details because I would rather like to stimulate people to look it up themselves and be convinced themselves. But this is one slide that appealed to me. If I can zoom in, it shows how what kind of alterations occur in depression. At molecular level, there is glucocorticoid release, glutamate excitotoxicity, decreased BNF, decreased intracellular signaling, and decreased synaptic function due to effect of stress. What happens at cellular level? Increased cell loss, increased neuronal atrophy, decreased synaptic plasticity, and increased cytoskeletal destabilization. So, in a sense, we can call it cellular aging or senescence also. That translates into decreased neuropil, decreased structural volume in hippocampus that we see in neuroanatomical studies. There is a decrease in neuronal function, maybe conduction velocity gets affected, decreased glial function, decreased neural network connectivity, which we can see in connectomics. All this clinically ultimately presents as major depressive disorder. So this is what happens in general with the brain of a depressed person. And if a treatment or a molecule can reverse this, it will help person recover from depression. So as we know, monoamines, how they are released, how they are reuptake, and then dendrites get affected first, and so that's why we see initial worsening and all this. Largely, we all know. So I won't go into much detail, but beyond that, different actions are there. And why were they considered? Probably, I would remember cyanapine as a molecule that showed that depression is beyond monoamine hypothesis because it does not seem to affect any sertraline, noradrenaline, or dopamine in clinically meaningful way. And yet, it does provide antidepressant effect. That is why it is called atypical. So, how does it actually work? It works via mTOR signaling, that is mammalian target of rapamycin. So, if there is a decrease in glutamatergic activity, which reduces excitotoxicity, it improves synaptic plasticity. There are changes seen in terms of increase in BDNF, increase in neurogenesis, all those tissue and morphological level changes, and the cellular and intracellular level changes. But sometimes we have to go by available technology and methods as to what to measure. Ultimately, it does help resolve phenotypic expression of depressive episode. And similarly, other molecules also, the traditional one that act to reuptake inhibition or other mechanism, they also act via different second messenger systems and intracellular signaling pathways. Majority of these clinically relevant neurotransmitter receptors are G protein coupled receptors, And with G protein, there are different subunits or subtypes GS, GI, and GQ. Depending on the receptor and molecule that binds, there are conformational changes in receptors which subsequently trigger intracellular signaling pathways like CAMP, protein kinase CRAB pathway, or BDNF PRK beta pathway. Tyrosine kinases do have single transmembrane unit receptors, but that is a different discussion. Probably it would be too comprehensive to include here. And these different signaling cascades, for example, it affects mitochondrial function, it affects endoplasmic reticulum function, which releases calcium, and calcium then goes and affects almodulin pathway and probably 10 other pathways. Ultimately, it has two or three major impacts. One is it affects transport of things in and out of cell. And sometimes these transports are mediated by chaperone, or we can say escort molecule. And later we will see that some of the medications do act as chaperones. Secondly, internuclearly, they would affect expression of various genes, and they would also act as epigenetic modifiers via histone deacetylation or methylation or demethylation. These are the common intracellular signaling pathways. This first one is that protein kinase A CRAB pathway. The second one is BDNF PRK beta pathway. We can see that there is a receptor, and that blue one is cell membrane, and how once bound to receptor, it triggers intracellular cascade, and they are more than one, and they are interconnected, ultimately affecting transcription and survival, growth, and neuroplasticity of cells. If you recall what we discussed minutes back, cellular destabilization, and with treatment that does get stabilized, and that is cellular level plasticity. Later it comes to synaptogenesis and every other thing. So this third one,
Doctor, excuse me, Dr. Nachiketa, can you be little louder, because your voice is
okay.
cracking because of internet connectivity or certain issues. So
Hello.
little louder if you can
Okay.
try. Yeah.
Am I audible better?
Yeah, better.
Okay. So these three images, I'll get back to that. These are just, I'm demonstrating the different intracellular pathways. I am not going into much details, but these pathways are relevant. For example, in this figure one, if you can see carefully, SSRI is mentioned, then there is NMDA receptor, glutamate, how it acts, there is BDNF and all those things. And these pathways do get affected even with our medicines that we use day to day, fluoxetine, escitalopram, each and every medicine. Action does not stop at neurotransmitter reuptake or at this neurotransmitter receptor level. So we talked about intracellular pathways, that is mainly cytosolic environment. In intranuclear level, as previously seen, different beta catenin and all those things then ultimately go to DNA and affect the different gene expressions. And that ultimately leads to regulation or increase or decrease of different proteins. And it has wide ranging effects, not just one. And this slide just displays what things occur at epigenetic level. For example, there is mention of amitriptyline, escitalopram, there is clozapine. Today, we are limited to discussion of antidepressants, what we call antidepressants. But this is what actually happens, and that's why clinically sometimes we see that some medications give unexpected effects like low dose antipsychotics, giving antidepressant effect. So again, antidepressant term is bit of a misnomer, just like we calling propranolol antihypertensive. It is an indication, but it can have other effects. Coming to that cellular destabilization or aging or whatever, that would trigger autophagy and recruit body's defense or repair mechanisms to sort it out. And that also has a role in depression, and antidepressants do help there to via different signaling pathways, primarily by stabilizing the cell. There is proteostasis and it has impact on mitosis, and that's why it has properties in treatment of malignancy also, as we'll see later on. So we think of these medications as a molecule for depression or as antidepressant, but they have other effects also. For example, fluoxetine reduces lymphocytic activity in high basal immune function. What I understand from this is probably it has anti-inflammatory property, but we have Tolbert present today who can shed more light on this. It can also directly act on T lymphocyte and modulate their proliferation. Thus, fluoxetine is immunomodulator too. Again, fluoxetine has chemosensitizing effect because it blocks MDR pump that we talked about, transport within and out the cell. So these molecules are having tremendous effect size in other disorders also. That brings about another question. If they are so effective in other conditions or as an adjuvant or whatever, why are we seeing less or inconclusive effect size in the primary indication that they were marketed for, that is depression? One explanation can be that not all depressions are same, just like not all fevers are same. And when we include participants in a study, we are going by depression as a phenotype based on any criteria. So there is a high level of biological heterogeneity which can dilute the results, be it a medication working in a condition or a medication not working in a condition. A biologically homogeneous sample would give us much more confidence in the result. And I have taken an example of fluoxetine because it has very high popularity as a Prozac and Prozac nations, and so many books are written on that. But almost all other antidepressants have one or the other such function, probably more than one. And that's why different specialties are now picking up on these molecules. For example, dermatology is picking up on a prothioidine and other molecules. Neuropathy, we see nortriptyline, duloxetine. Chemotherapy, chemosensitization, olanzapine and others are used in chemotherapy-induced nausea, vomiting. So again, they are not just antidepressants, and because what we discussed, we can say that they affect different pathways, have multitude of effects, have multitude of indications, at least they are upcoming via drug repurposing. Thus, so-called antidepressants that are seen as harmful or having inconclusive effect are actually showing remarkable results. So, number one, antidepressant term itself is a misnomer. Number two, we are not using it just for depression, we are using it in other psychiatric condition also. Number three, it has implication beyond psychiatry. That's why I would consider that antidepressants are not happy pills. Plus, not being a euphoriant, I won't consider them addictive. Just as cocaine or other addictive substances. And after reading all this, I had a question. Why did not I know this before? Because research has been there since probably 90s. The more prominent one I could find was from 1996, where they were discussing intracellular pathways, although in brief, but it is there. But somehow, molecular actions, intracellular signaling pathways, these things did not get as much light as monoamine hypothesis. However, scenario is changing, and nowadays mainstream textbooks have started mentioning actions beyond neurotransmitters and particularly actions beyond monoamine hypothesis. In conclusion, they are not euphoriant. They improve cell functioning, cell plasticity, intercellular communication. Due to that, brain is able to function better, handle the physiological load better, probably control the emotions better, and end result is a more healthy brain that restores mood, emotions, thoughts, and behaviors to normalcy. Also, they are useful in other conditions too. That is why they are more than happy pills or even antidepressants. Thank you. I'll stop my screen sharing.
So, thank you, Dr. Nachiketa. So it was, I think, nicely conceptualized and lovely elaboration by our speaker on from neurotransmitters level to cellular mechanism, everything I think he tried to touch. And we have many PG students joining in. So I can see we have a very good attendance. We had around 99 participants for this talk. And I think everybody must have been thrilled seeing the theme that antidepressants aren't happy pills. Now I think I would start the discussion part. Yes. So we have Dr. Vijay, I think Divay Mangla, Dr. Divay Mangla, he wants to know, Dr. Nachiketa, he wants to know from you, do other psychotropics share same story? I mean, beyond neurotransmitters?
Hello, Dr. Devai. Very good question. Yes, majority of our medications do share this, that is actions beyond neurotransmitter, including antipsychotics, even valproate and other what so-called mood stabilizers or I would say antimanics. And primarily, if we recall valproate and lithium, these two have had mention of intracellular actions probably bit more than antidepressants in literature. Although they would be mentioning like it is evidence is still not yet strong, but this is putative mechanism. But yes, majority of our medication do have this, do share this concept. I would say not property.
Okay. So I think Divay Mangla's doctor, he wants to ask another question, which is what is strength of evidence of antidepressants in autoimmune disorders? As you were mentioning that antidepressants are not only happy pills, they are much beyond that. So like even if we consider them as a antidepressant, like being happy pills, they are much beyond that. So what is their role as in autoimmune disorders?
So rather than quoting n number of articles or research, I would answer it clinically from a clinician's perspective. For a moment, let us consider diabetes or hypertension. Those are parameters, blood sugar or blood pressure, and their allostasis and everything gets affected. There is uncontrolled diabetes and uncontrolled hypertension, swings of hypertension, and these kind of people, they do present with depressive symptoms, primarily because that does impact a brain's functioning. And that's why tired brain presents with depressive symptoms. And there, our medication helps not only in improving depression, but also helps improve the allostasis and thereby better glycemic and uh, hypertension control. Similarly, if we consider our immune system, it has two or three arms, I would say. One is pro-inflammatory arm, other is anti-inflammatory arm, and there is a balance and homeostasis. Allostasis comes into picture there. Secondly, immune system and coagulatory system have a very close tie. So these things do tend to occur together phenomenologically also. These patients, autoimmune conditions, they have high prevalence of depressive and somatic symptoms. And there it has its purported effect as well as it helps improve allostasis in immune systems also. That balance between pro and anti-inflammatory arm, and thereby it helps. Clinical evidence, again, the same question, biological heterogeneity, everything. And I would say that despite of all those limitations, it is showing promising results. We can look it up on any uh, search engine or index.
So, I think so. Thank you for the elaborative answer from clinical level to neurotransmitters to even cellular level. I think you covered it all. I think we have, I cannot, I have the greed of getting contributions from our learned chairperson. I can see Sandeep sir.
Yeah.
So anything which you would like to.
Dr. Nishka, thank you. Now, the question which has been asked, what is the so-called strength of evidence? At present, we can look at this from a multiple perspective. First, that antidepressants have not been directly tried in autoimmune disorders, but we have animal level studies evidence. So that is the simpler answer to that. The second way to answer that is, in the COVID times, we have seen antidepressants like fluoxamine and other antidepressants being shown to have an effect that they reduce the chances of developing COVID infection. So that's again one of the anti-inflammatory pathway which is being considered. The third is that lot of antidepressants are now being repurposed or are being tried for different other conditions, and one of them are inflammatory conditions. The third point to understand that we have a clear cut understanding that depression itself is a result of stress, and the whole pathway of immune pathway comes into the picture. So if we look at all this from a clinical point of view, at present we know that for any drug to be considered how it will be used, it needs to go through the regulatory pathways and everything. So we have not reached to that level that we can say directly that you can use. But the other way to, from a clinical point of view, that okay, patient has depression and has SLE, maybe adding an antidepressant is always a good idea, that it may also have some positive impact on the SLE.
Thank you, sir. And recently, I think COVID phase also, there was lots of discussion on the same, like the immunomodulator effects and all. There was lots of talk on about fluoxamine being used, being even helping for COVID patients. Now, I would like to get contributions from Dume sir. I think his clinical inputs regarding the same.
Niska and Sandeep and Nachiket and all the people attending here. My family and I have just come out of a very difficult phase. My wife went through triple negative breast cancer. And I can tell you for sure on experiential basis that I tried to, reading the literature, I tried to put on fluoxetine. And there is something in fluoxetine that enhances and creates a more effective way of the drug distribution or something that goes around. And I would rather suggest people that if you have somebody on chemotherapy, it would be ideal for them to go on a 20 to 40 milligram dose of fluoxetine. It somehow, I'm telling you from experience, it somehow enhances the effectivity of all the chemo medications that you do. I'm not a very biologically inclined person. I am an experientially inclined person, and Sandeep knows me as a person who would works from the ground root up, and whatever has been my experience has been the experience of the common man. So I'm not much into any of your academic issues, but what I know from experience is that I still feel that if it has worked in my house, it can work on anybody's house. And fluoxetine probably finds a new way. It helps keep the patient positive. It helps affect the end organs with the effectivity with which you design the chemotherapy. And it also protects you from some sort of recurrence. Because what my wife had is a triple negative breast cancer, which is a mutation. And if it's a mutation, none of us know what is the future course of event. But I'm very positive that from a psychiatric point of view, if you have positive mindset, which can also be, brought about by fluoxetine, you will have positive results from cancer. That's my case, but this is an experiential thing that I would like to share with all of us who is joining from the IPS. Sandeep has to add anything else from
Yeah, just one
academic?
small point here. In fact, I was today speaking in another forum. So I just had one part of the talk was repurposing of psychotropics, and there now a lot of literature is coming that antipsychotics and antidepressants are being repurposed for management of cancers in animal models, and they have also been shown to increase chemosensitivity and radiosensitivity in patients with various cancers. So if the patient is receiving this, they respond better to chemotherapy and radiotherapy. These are again animal model studies, but human studies are yet to come in the so-called structured format. Yeah.
What I'm saying is that I've got a in-house thing. 1
I
year down the
agree with
line,
you.
we are clear. 1 year
I
down the
agree.
line, we are clear, thank God, and thanks to the blessings of all of you, we are clear at this point of time. So, Nachiketa, keep this in mind when you're trying to teach your juniors that psychiatry not only restricts itself in mental illness, and the psychiatric medication goes far beyond working in humanities where it is not really thought about. Okay?
Thank you, sir.
Yeah.
So I understand the last, I think, few years has been very difficult for sir, and we are blessed to have his personal experiences, clinical experiences. He shared them, so it was wonderful. Now we have Dr. Nachiketa. We have another question coming up. It is like we all know that low dose antipsychotics, they have antidepressant effects as well. We all know about olanzapine. We use risperidone. Low doses, we know that even for aripiprazole, there has been evidences. So does it mean schizophrenia with predominantly negative symptoms should actually be termed as depression and not schizophrenia? So anything on this, if you have to say?
Hello, Dr. Vimla. Interesting question. To answer that, we are going into taxonomical issues, how these classifications are devised. For example, blood sugar, fasting blood sugar of 150 is called diabetes because that is its operationalized criteria. We need to quantify a spectrum of blood sugar. However, definition I would say would be inability to handle glycemic load, just like a person without diabetes who can handle. That way, in psychiatry also, we need some operationalized criteria, and DSM and ICD are those. They operationalize it or quantify it in terms of duration, maybe in terms of severity, 5 out of 9, or whatever we read in DSM and ICD. What they are based on, number one, criterion A is based on clinical presentation. That is a phenotype. And these are different phenotypes. If we can compare it we can probably compare it with viral fever phenotype that is low grade. We can compare it with high grade fever with rigor. And these are different phenotypical or clinical descriptions. So those names have been given. Partly these are based on consensus, voting process or whatever. People opine that they should be this. And second part, they did have some form of reliability and validity compared to totally unstructured approach. So they were better than totally unstructured approach. That's why these terms came into picture. And we can see that they are evolving and changing, and catatonia was once schizophrenia and now it is not, and so many things. So standing there, they want to give it a name, we give it a name. However, clinically, there are studies that show that antidepressants have effect in negative symptoms of schizophrenia. And very crude level, these are pro-serotonergic and pro-dopaminergic agent, whereas the antipsychotics, what we call, are in a very crude and inaccurate way. I am clearly mentioning that this is inaccurate just to demonstrate a point. They have almost opposite actions at times. So antidepressants are antimanics and that can produce depressive features, and antidepressants can correct them. And there is a large overlap with negative symptoms of schizophrenia. So it may be considered a form of hair splitting at phenotypical level because we have not had biological constructs, we have clinical constructs. Probably I have clarified something rather than confuse more.
So anything to add to this, Sandeep sir?
Yeah,
Because this often comes to our mind that
this is simpler thing to understand from a phenotypical point of view and a biological point of view. A person with negative symptom most often or usually do not have distress as compared when we look at a patient with depression. So the effect in a person with negative symptoms is more of a blunted effect, and he does not express his distress. Suppose if I always teach my student very simple thing: if the caregiver is distressed, it is negative symptoms. If patient is distressed, it is more likely a depression. Very simpler to think that a patient of with negative symptom will not reporting that much of distress as much as a patient of depression will report. That's a basic clinical thing to remember. If you remember that, you'll be always able to distinguish the two syndromes, and then you will look for other symptoms. In terms of neurobiology, again, both have different level of neurobiological involvement. In terms of neurotransmitter, both have a different level of neurotransmitter involvement. From all point of view, there are differences. So I'll just want to, if you want to remember the clinical point of view, the distress word, if you remember, I think you'll be able to often distinguish between negative symptoms and depressive symptoms in a patient of schizophrenia per se. So patient of schizophrenia will also have depression, remember that. But a person with depression will be distressed. Person with predominantly negative symptoms will not be that distressed.
So thank you for your inputs. You made it, you gave the answer in such a lucid manner, and now I think it should be clear to all, because we often get confused over these issues. And then something interesting, like which has been talk of the town, I would say, because many new antidepressants are coming up with this issue. So Dr. Abhijit Kishore, he wants to ask, does antidepressants have effect on cognition? So Dr. Nachiketa, if would you like to address to this question?
Short answer is yes, it can.
So there has been recent lots of we have many newer antidepressants in our basket now.
True.
Which
they are
helps.
marketed as pro-cognitive, but then almost all antidepressants improve brain function, thereby they improve cognition also. However, again, same thing, we are discussing phenotypes and clinical constructs and other technical issues. But coming back to the point, there is attention deficit, there are other overlapping areas, and we have molecules that act on these, and we have clinically seen, for example, bupropion. We see its effect in attention deficit related executive functioning. We see its effect in depression related cognition also. So yes, they can. Again, it is personalized. Who will get benefit to what extent with which medicine is a very individual and very personal thing. But probably what I can say is that it is not limited to one particular molecule.
True. So I think Dr. Sandeep sir.
Yeah. One simple way to answer this is that patients of depression have cognitive impairment. And once you start treating depression with antidepressant, their cognitive impairment starts improving. That's how antidepressants act on the cognition. But if you say antidepressants are given to patients of Alzheimer's disease or something else with cognitive impairment, is their cognition going to improve? My answer is no, and that has been clearly shown in the antidepressant trials when they have been evaluated in patients of Alzheimer's disease or people with MCI or other things. They don't improve their cognition. They improve the cognition only in a patient who was depressed and who is recovering. So they basically reverse the cognitive dysfunction which was seen during the symptomatic phase. That's the simpler answer to that.
Yes. So and yes, we all know that depression is not only about mood. So we have now many new molecules, and we are targeting the cognitive, like many new antidepressants are coming with this that claims that they improve cognition as well, which is wanted, because to have a good quality of life and everything, we need to have that cognitive part working well. It stays for long, as we all know. Dr. Tirthankar sir, I think sir has some query for Dr. Nachiketa sir. Do you want to say that negative symptoms, it affects mostly cognitive area and less emotional area, whereas in depression it is opposite? So I think he is referring to the questions we were just discussing about negative symptoms of schizophrenia in comparison to the depression. So Nachiketa, Dr. Nachiketa, do you have something to add to this? I think Sandeep sir, he explained that part.
Yes, exactly. Yeah. So I would say that they are affected in both conditions, and that motivation, anhedonia, these things are probably the overlapping part here. But depression, yes, I mean, it affects both, and a negative symptoms, schizophrenia is also affecting both. But probably clinically, as Sandeep sir described, emotional distress is less seen in negative symptoms of these compared to depression.
Thank you. So I think we have covered most of the questions. So I would like to get like brief viewpoints from our chairpersons, respected chairperson. I think Dome sir, I would like to invite Dome sir, and then subsequently Sandeep sir for their take on.
I think Sandeep, you can summarize.
Thank you, sir. No, I think Dr. Nachiketa made a very good presentation here for us to understand that how antidepressant works beyond the serotonin syndrome system, or the other way to look at is the serotonin system is not just involved in depression, but it is involved in many other conditions. So what we need to understand that serotonin is one molecule per se, or one neurotransmitter, but the second messenger systems get involved in different diseases or different disorders. And again, there's a cross communication between different neurotransmitters in the second messenger system, that antidepressant go beyond what we just understand that they are antidepressant. I think that point has been very well made by the presenter, and that is what I would say we all need to understand. And possibly from a consultation licensed psychiatrist perspective, as I said, if you understand the antidepressant or the psychotropics action beyond antidepressant or antipsychotics as anti-cancer agent, anti-inflammatory agents, and so on, maybe then you will be in a better frame of mind to communicate with your colleagues to explain them that why antidepressants are required in a patient who is suffering from cancer or maybe an SLE. So with this, I'll close
I would
my
second
remarks.
Sandeep on that. That we as psychiatrists in a licensed psychiatry type of atmosphere should be a pivotal, in a pivotal role of trying to advise people that when you are giving a cocktail of medication, an antidepressant has to be a part of the treatment on discharge of a patient who has undergone chemotherapy. I would rather put it that it should be an adjuvant even before the chemotherapy has started, because it keeps the mind buoyant, it keeps the will active, and therefore the effect of chemotherapy is much more felt and the effect is much more better. So we as IPS members should also remember that we have a big role to play not only in treating people with depression, but with a liaison type of activity wherein we try and tell the cancer surgeon, boss, आपका chemotherapy चलेगा, मेरा antidepressant चलेगा. It will protect the brain, it will enhance your effectivity, and it will improve the quality of life during chemotherapy and post chemotherapy. So if you're looking at it, cancer is coming as an epidemic. Every second or third house has somebody who is diagnosed, which means our role is now expansive into the treatment of cancer. It was there on other aspects, it's there on cancer. And Dr. Nachiketa has given you the reasons for why we should sort of include include antidepressant as an adjuvant and a positive adjuvant to cancer therapy. Also to an autoimmune illness. We've got a colleague, Nishka would know, who has an autoimmune problem and who has done very well with the addition of an antidepressant. And there has been a time that she has not been on antidepressant and she has not had a good outcome. Which means that we can make a miracle happen. Remember this. Over to Nishka.
Yeah. Sir, it's always a pleasure. I often feel like in many forums, I always say that many people have power to prescribe drugs, but psychiatrists are the only ones who have the power to prescribe happiness. But yes, on the other hand, it's very important to understand that when Prozac came, it was approved in 1987. There was a concept of like happy pill, like if you want to get more happier, if you want your life to be more like jolly, then you should start taking like if you take antidepressants, but it's not that. We need to understand they help in moderating the neurotransmitters once you are not happy or you are depressed. So it's not that they are to be used as a happy pill. Another side of the coin is like antidepressants, they do have side effects. So psychiatrists, like they understand the balance, and with the help of new molecules coming up, we like I think from today's talk, it was very clear from Dr. Nachiketa's inputs that there are very complex mechanisms working at neurotransmitters and cellular levels, which needs to be understood. It's not that any antidepressant we are going to prescribe to anybody and he or she would become happy. Now, we are lucky that we have Dr. O.P. Singh sir joining us. So it is a very interesting topic, and I think I would like to get contributions from sir so that we can benefit from his clinical expertise. Dr. O.P. sir, sir is here. Dr. O.P. sir?
Sorry for I have joined late.
Yeah.
I've joined late, so I'm not privy to what was happening. So just give a specific question, I will comment.
So today's topic was antidepressants aren't happy pills. So what is your take on this?
Obviously, they are not happy pills. Till now, they are from negative to they will come to neutral, but still we do not have mechanisms where from neutral to positive they will go. But some people use them and they say that there are benefits. But still theoretically and practically it is not there. So we cannot use it indiscriminately where we are not able to clinically diagnose. That is my opinion. Thank you so much.
Thank you so much, sir, for joining in. And so it has been a blessed evening. We had more than 99 attendees today and a lovely discussion. And we also learned a lot from our learned chairpersons, Dr. Sandeep Sir, Dume Sir, and then words of blessings we got from our president, sir, Dr. Raju Sir, then SAC President, Dr. Saha Sir, so, and our secretary, and it has been a studied show. And now I would like to hand over to Dr. Tirthankar sir for concluding remarks and the rest of the sessions.
Yeah, it was a really excellent presentation by Dr. Nachiketa, and very interesting session. And previously we were just thinking about the actions outside the cell. And he has today dealt the topic into the cell, and he told everything what's going on inside the cell, the intracellular pathway and everything. So we don't have to think about neurotransmitter level only. So we need to think beyond neurotransmitter level. That's the crux of the today's presentation. And as Dume sir and Sandeep sir has said, that it has a multifaceted action. So multi-systemic action of these, our psychotropic medicines, need to be understood by everyone, and particularly so far as consultation liaison psychiatry is concerned, because I often find in my routine practice that the other medical people, medicine consultant and other consultant, the gastrointestinal consultant, they don't understand. And I find not a little bit about this, our psychotropic medicine. Whenever something happens, they immediately ask us to stop the psychotropic medicine, and they think that psychotropic medicines are doing the negative thing and is the notorious thing. But in reality, it's not like that. So this particular message should be percolated to them. They should know that this inflammatory, anti-inflammatory property and other properties of this psychotropic medicine, they should know, so that they can welcome these psychotropic molecules quite in a more intense way than the current scenario. The current scenario is not very bright, I suppose. That's what the practical scene is concerned. Whatever we say theoretically in our own forum, I don't find the people in the physician community, they don't find the psychotropic molecules has so much of multi-faceted action. They don't know even, and they don't have that much of concept also. I find there must be some exception definitely, but majority of them they don't have. And,
good for us, Tirthankar.
And yeah, thank you, sir. And with that, I hand over my mic to my chairperson.
Dr. Sandeep sir has something to add.
Yes, Sandeep sir, yes, his input is very much.
I just want to add that the basic fact which we need to understand, that it is only when the patient is too sick that they like to stop antidepressant or psychotropics. But we need to remember that if we psychiatrists prescribe 100 prescriptions of psychotropics, physicians across countries prescribe maybe 200 prescriptions of psychotropics. So let's not go into that fight kind of a thing. I would say we just need to tell them what all can benefit, rather than saying that they don't do it or they ask us to stop. It's not that. They, in fact, if they don't understand anything for their patient, they prescribe psychotropics.
Right. Yes.
Agreed.
Yes, agreed. So with that, I hand over my mic to Dr. Manu Arora, my chairperson. Dr. Manu, are you there? Yes, Dr. Manu. Dr. Manu, are you there?
I think he's trying to unmute or.
Yeah, I don't know.
Another thing, that depression, we all know that depression is not a sign of weakness. It is just that we have been strong so far, and we do have help available. So, and it's wonderful to know that there has been not only for this depression, but we have multimodal action for these drugs, which helps. Like we had practical experiences being shared. I think Manu sir is not there because
There may be some problem in the connection. Somebody can
Connectivity, yeah,
conclude.
yeah.
Somebody can
Because-
conclude. Yeah.
Yeah.
I think Tirtha, you can conclude.
Yeah, I think I have rang him, but he's not picking up the phone. Probably some connectivity issue or something. Anyway, so we can conclude the program. I thank you all the delegate, and it's been a fascinating program. The lecture, the presentation was excellent. We have almost reached 100 marks. Yes, Dr. Manu, you are there. Yes, if you can please conclude the session, and with word of thanks, we were waiting for you.
Oh,
Yeah.
see, I think this has been the starting of a new way to understand things and certain topics which have been discussed today. I think it makes a lot of sense because this is not the way usually we see about antidepressants and the effects, and especially when Dr. Sandeep Grover were talking about a lot of things about antidepressants and certain cognition, other things. I think it makes a lot of sense to understand about new perspectives about antidepressants, especially about COVID, cognition, whatever it is. So I think engaging people to discuss about these topics will make a lot of sense in our understanding and about widening of horizon about the scope of usage of certain psychotropic drugs. Today we are talking about antidepressants, but over a period of time, when we talk about other drugs, I think it's widening the scope and widening our understanding and research potential into that. So I think that's a wonderful presentation, wonderful discussed, wonderful comments by people who have come to our this particular forum. I think it's a wonderful situation. Wonderful. Thank you.
Thank you, everyone. So I can leave. Yeah.
Good night. Good night,
Yes,
everyone.
good night.
Good night,
Thank you.
everyone.
Thank you. God bless. Take
Thank
care.
you.